And we're also seeing more data now that shows that we can improve survival by using CYP17 inhibitors when prostate cancer is more localized and not just in the advanced settings. I think we're in a scientific golden age for prostate cancer and probably cancer as a whole, but we're talking about prostate cancer today. So I'm excited to be sitting on the front lines, seeing the new ways that we can help our patients. But I do still think CYP17 inhibitors will continue to be one of our main weapons against prostate cancer for a very long time.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Andrew Ruplin, Clinical Oncology Pharmacist at Fred Hutchinson Cancer Center in Seattle, Washington, about the CYP17 inhibitor drug class. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome and thanks so much for joining us today, Andrew.
Thank you. It's great to be here.
So let's start off today with a brief overview of the history of CYP17 inhibitors and how they've sort of found their way in the field of oncology.
We're going to go way back. Medical science has actually known since the late 1700s, actually, that there was a direct connection between the testes and the secondary sex organs, and that actually castration could affect the size of the prostate. If we fast forward to the 1800s, we then had the first described case of prostate cancer. In the early 1900s, we had coining of the terms hormones and testosterone. And then in 1935, testosterone was first chemically synthesized independently. While the effects of surgery and radiation were understood to improve outcomes for patients with prostate cancer, much of the treatment of this cancer, especially metastatic, in the latter half of the 1900s was based on reducing or ablating androgens, namely testosterone, most often through castration or administering female sex hormones. The first CYP17 inhibitor that received mainstream attention for treatment of prostate cancer was actually discovered accidentally through a side effect. Ketoconazole, the antifungal, caused gynecomastia in some male patients, and so it was further studied in patients with prostate cancer and has demonstrated reductions to both circulating testosterone as well as reductions in the prostate-specific antigen, or as we often say, PSA, which is often used to track response to treatment. However, unfortunately, ketoconazole has never demonstrated an absolute survival benefit in randomized trials even to this day, and therefore it never received approval by the FDA to treat prostate cancer. Identification of CYP17, however, as a target to decrease androgen production led to the first synthesis of a dedicated inhibitor of CYP17 named abiraterone acetate in the 1990s. But it would also not be until 2011 when there was sufficient evidence through clinical trials for the FDA to approve abiraterone as treatment for castrate-resistant prostate cancer. And since then, abiraterone has been studied in many different stages of prostate cancer and has demonstrated clear benefits to survival for patients with metastatic or non-metastatic prostate cancer and in the castrate-sensitive setting as well. Other selective CYP17 inhibitors were developed, but they actually never made it past clinical trials, so abiraterone remains the sole approved CYP17 inhibitor.
That's really interesting. I just always love with those examples of kind of those unexpected, happy little accidents, like things that are found as like, it wasn't really what we were looking for, but hey, this is pretty cool, and ends up being actually meaningful and leading to something that really truly is helpful. So it sounds like that was the case in the history of the CYP17 inhibitor. So thanks for sharing that. So let's talk about a little bit more detail about the mechanism of action. Can you talk a little bit about how CYP17 inhibitors work?
So we keep saying CYP17 inhibitor, but the more specific conversion enzymes are the cytochrome P450 or CYP17 hydroxylase and CYP1720 liase, which sequentially catalyze the conversion of, and bear with me here, pregnenolone and progesterone to 17-alpha hydroxypregnenolone and 17-alpha hydroxyprogesterone, which are then converted to the weak androgens, DHEA and androstenedione, respectively. Both DHEA and androstenedione are eventually transformed into testosterone and DHT, which is a more potent form of testosterone. By denying prostate cancer cells testosterone and DHT, cancer cell growth and proliferation is halted, and in some cases, cell death occurs as well. Abiraterone is usually paired with androgen deprivation therapy, also commonly referred to by its acronym ADT, which serves to further reduce testosterone production by halting the production of androgens in the testes via the hypothalamic pituitary gonadal axis.
I might need a picture to make all that make sense. And no, thank you. I mean, I think it just speaks to the complexity of both these CYP17 inhibitor therapies that we're discussing today, and then generally all sort of hormonally manipulating therapies. It's very complex, which I think just makes it even more amazing that we kind of figured it out. But also when we think about having to explain this to our patients, I think there's an important level of understanding that we as clinicians need to have a handle on, but then we also then have to translate that maybe more simply to our patients. But thank you for going into that depth, because I do think, as I said, nurses need to make sure that we really understand what's going on and how it's working, because ultimately that is what directly leads to potential side effects and symptoms that patients might encounter. So thanks for going through those kind of twisty words that you got through. I'm impressed that you got through them. I definitely could not.
Thanks.
So what are some of the primary subclasses of the CYP17 inhibitors? And maybe you can highlight an example of any specific agents, anything that is newer or more likely for our clinicians to see in practice.
So while ketoconazole represents a subclass of CYP17 inhibitor, because clinical trials have not shown a significant benefit to survival, it's actually not often used in contemporary practice in the United States and would not be recommended in the majority of cases when there are superior alternatives that exist. It is, however, reasonable to consider in select circumstances, and actually we have support from consensus guidelines for treatment of castrate-resistant prostate cancer that do support that. This is partly because it is low cost and has a relatively favorable and tolerable side effect profile when compared to chemotherapy. So you may encounter the odd patient who might be eligible for ketoconazole, although in my kind of 5-year career in RGU clinic at Fred Hutch, I've maybe seen it less than 5 times. So really definitely not the standard nowadays. Therefore, the only approved CYP17 inhibitor available currently is abiraterone acetate, which I kind of alluded to earlier. However, after the initial approval of abiraterone, a micronized formulation that can be given with or without food was developed and currently only exists as a brand name medicine. The micronized formulation is dosed initially at 500 milligrams once daily, compared to standard abiraterone, or that original formulation, which is 1,000 milligrams daily. The standard abiraterone formulation should be given on an empty stomach, since food can dramatically increase absorption and unpredictably increase absorption as well. Patients either on the standard formulation or the micronized formulation should both get prescriptions for oral steroids. Officially, the standard formulation is approved to be given with prednisone, and the micronized form is approved to be given with methylprednisolone.
Let's move on to those toxicities. So what are the typical toxicities, adverse events that our patients might develop when they're on the CYP17 inhibitor therapy? Whether it's an individual agent, as you said, sometimes they are maybe often given alongside other therapies. And so maybe it's hard to differentiate what comes from what. But can you talk a little bit about what patients experience in terms of side effects, toxicities from this therapy?
I will say from this point on, I'm really only going to speak about abiraterone, since ketoconazole is a legitimate treatment, but it's a little bit more historically used at this point. So it's not really recommended in most cases, and we might talk about that a little bit later, but kind of speaking about abiraterone and focusing on abiraterone specifically as the main potent CYP17 inhibitor that we have in our arsenal, abiraterone can cause liver injury, and that's very well known. So patients should be monitored routinely, especially in the first few months of treatment. And it's recommended that actually patients be monitored probably about every 2 weeks for the first 3 months. And then if your patients are doing well after that, about monthly is probably appropriate. And if you have a very stable patient for maybe a year or longer, you may actually be comfortable monitoring less frequently than that. But what I would also say is during this whole period of time, or any period of time, if liver function tests are increasing, so transaminitis or bilirubin especially is what we tend to think about, if these are increasing, then abiraterone should be stopped to allow for recovery before you even decide if it's appropriate to continue with the treatment or not. The second most common toxicity that I think of, and is especially unique to this mechanism in this class, is mineralocorticoid excess. Mineralocorticoid excess tends to manifest as hypertension, low potassium, and edema. So those are kind of the main 3 that I think about or discuss with patients. We do sometimes rarely see cardiac events such as atrial fibrillation or cardiac failure. Although what I would say is in the grand scheme of things, these only occurred at a slightly higher rate than patients on ADT alone. I mentioned earlier that patients on abiraterone are almost always also given ADT at the same time to suppress testosterone. And we think that the magnitude of increase with these cardiac events with the addition of abiraterone to ADT is not that significant overall. So we're not dramatically increasing the side effect profile simply by adding on abiraterone.
Thanks for that overview of the side effects. One side effect that I always kept in my mind, because I did not work specifically with patients with prostate cancer in my direct clinical practice, but the one that I always remembered was the notion of tumor flare. Can you talk a little bit about what tumor flare is and how it presents itself for patients on these therapies?
What I would say is that tumor flare, the first thing is that it's not actually a side effect of CYP17 inhibition. So tumor flare occurs because prostate cancer cells are inherently receptive to testosterone as a growth stimulus. And the phase of treatment when patients might see tumor flare is when they're initially starting ADT, and not just any ADT, but specifically the gonadotropin release hormone agonist class. So primarily we have agonists and antagonists. Both of them work in that hypothalamic pituitary gonadal axis that I mentioned. But the agonists, because of that whole axis and because of positive feedback and negative feedback, the patient who starts GnRH, that's that acronym, agonist, can have an increase in their testosterone, and really in every case should have an increase in their testosterone because that's how the agonism process works. So we get an initial surge in testosterone, and negative feedback loops eventually shut that down and then decrease the amount of testosterone that's produced from the testes. So really that's just a complicated way of saying that a patient who starts a GnRH agonist, we commonly use Luprolide in our clinic, but there's also others like Goserelin and some others that I don't often see anymore. But your patient who is starting Luprolide is expected basically to have a surge in their testosterone that could produce a tumor flare. Now, that tumor flare may not be evident in all patients, and some patients are at higher risk for developing tumor flare. And those especially include patients who have kind of more symptomatic or a higher volume of disease when they start. So the two kind of main things that I think about in a patient who could have tumor flare is worsening urinary obstruction. If we think about if we're feeding the prostate cancer, the tumor at the site of the prostate could grow larger and obstruct the urinary pathway. Or patients who have bone metastases, especially to the spine, there is that risk that if there's growth of those bony metastases, that could cause spinal cord compression and could ultimately result in weakness or paralysis, especially of the lower extremities in those patients. So definitely something we want to avoid in at-risk patients.
So as you said, that is not technically caused by the CYP17 inhibitor that they may be taking, but because it's often prescribed alongside some of that ADT therapy, it could be something that presents itself for patients as part of their overall treatment plan. But it is important, I think, for nurses to be able to kind of separate those two of what the root cause is, and so that, again, they can translate that information to their patients.
Yeah, and patients will often start ADT before they start abiraterone. I say that kind of simply as a product of the logistics, I think, of healthcare. So Luprolide, we can give as a quick injection on the same day as their visit if a patient is ready to start, or even within that week. But sometimes we find that abiraterone requires a prior authorization that, depending on a patient's insurance, can take several weeks potentially before we get a determination. And then, of course, there's filling sometimes at a specialty pharmacy. So patients, there's sometimes a lag period between they start their abiraterone and their ADT. And honestly, that's okay.
Well, thank you for kind of going off on a small tangent, but I think that was very helpful for me to be able to kind of put those two things together. So now let's move on to discussing how we help to manage, treat potential toxicities. What are some of the pharmacologic strategies that we can use to help patients manage those known expected toxicities associated with the CYP17 inhibitor drug class?
So patients on abiraterone, regardless of the formulation that they get, they also have to receive an oral steroid every day while undergoing treatment due to the risk of that mineralocorticoid excess that I mentioned earlier. CYP17 inhibition by abiraterone leads to the loss of negative feedback on the adrenocorticotropic hormone, or ACTH, you often see abbreviated, through a relative cortisol deficiency, which then results in higher levels of ACTH, which then cause the formation of excess precursors, including those mineralocorticoids that are upstream of the CYP17 inhibition step of androgen formation. And yes, as you said earlier, I strongly recommend you look at pictures of these things because I think it makes it really much more tolerable for both clinicians to understand. And if you're explaining it to patients as well, I strongly encourage you find a resource that at least simply explains what this whole pathway looks like. So in brief, having patients taking an oral steroid every day helps to decrease the amount of ACTH that's produced and then mitigate the formation of excess mineralocorticoids. So that's why it is so important. I emphasize with my patients that they will be taking a steroid. It is a low dose steroid. It's really quite low, and they only take it once or twice a day. And put some numbers to that for abiraterone in the castrate sensitive setting, we would really just do 5 milligrams once a day. Now they do it every day, and it is a part of their treatment. I would encourage them to think of it as a part of their treatment so that they can maintain adherence to that medicine and be successful at preventing those side effects.
Yeah, and that's important. I think you touched on a really important point there of emphasizing to patients that it is part of the treatment. It's not optional. It's not when you need it or when you think you need it, but it's something that needs to be taken consistently with their treatment. So, and I'm sure we'll reinforce that here shortly when we talk about education. For nurses and maybe for pharmacists as well, what are some administration considerations that we should keep in mind when our patients are being prescribed the CYP17 inhibitors as their therapy?
So patients specifically, although often perhaps through education by their nurses, need to understand that they have to take the standard unmicronized abiraterone formulation on an empty stomach. So we define that, and by we, I mean kind of me personally in my institution, as well as kind of the official FDA-approved package inserts for this treatment. They define it as at least 1 hour before food or at least 2 hours after food. When I say food, I really kind of specifically mean anything that has sugars or fats or calories to it. I am excluding something like black coffee. I do have patients who say, well, can I drink my coffee in the morning? And I say, yes, but please don't put milk and creamer and other additives to it. So really, it should just be a neutral liquid that doesn't have calories associated with it. That reason being is that, as I mentioned earlier, food, especially fats in food, which I'll allude to a little bit later as well, why I called that out, can dramatically increase absorption of abiraterone and put them at risk for having worse side effects or severe toxicity. Another education point I think is important then is if your patient is switching between the micronized and the unmicronized formulations for whatever reason, they should also be educated specifically on the differences between can they take it with or without food, or must they take it on an empty stomach. I don't see that often, thankfully. It's not really that I see insurances kind of pushing patients to switch their formulations, but from a best safety practices, absolutely our patients should understand the difference between those two. I will also say that there is published data and guideline recommendations that do support administering only 250 milligrams. So that's about a quarter of the standard dose of the standard abiraterone formulation, but doing so with a low-fat meal. And this helps to reduce the number of tablets that have to be purchased. But some clinicians may be uncomfortable doing this since there is no agreed upon single low-fat meal, as the authors originally defined it, that can be definitively and safely eaten with this low-dose abiraterone. And additionally, some clinicians argue that the quality of this data is lower than the major phase 3 trials, which showed the true benefits of these treatments. And those original phase 3 trials have always used 1,000 milligrams daily of standard formulation abiraterone on an empty stomach. And I think for most patients that should be followed. But I understand this is a high-cost medicine for a number of patients. And there are ways that we can try to be strategic and adaptable and potentially kind of abuse that interaction between food and the medicine in that case. The last point I just want to touch on briefly is that people who are pregnant should not handle this medicine as it could affect the developing fetus due to suppression of testosterone and stopping the formation of testosterones.
Thank you for all that. Wow. I mean, I think the overall notion of oral therapies that we are sending our patients home with and kind of sending them on their way to basically dose themselves every day for this very important treatment. You know, my mind always just focuses on the right number of pills at the right time or the right frequency. But I think my eyes are now open to, well, are they taking it at the right time? Yes, but are there those restrictions of what interacts with their medicine, whether it's food, grapefruit juice for some medicines? There's just lots of things that I think obviously we should include in our patient education, but just doesn't that make it more complex? And then when you bring in the notion of possibly, though it's not maybe standard of care in this situation, like there might be situations where we could actually intentionally ask them to do something that makes the drug work slightly different or is a little different absorption. And so like just adding that another layer of complexity, but for all the right reasons, as you mentioned, it would decrease the pill count. It might help with financial toxicities related to these very expensive therapies. And so really interesting to think about just broadly across all types of oral therapies and just how we know it is such a different way to work with our patients and coach them on how to take their therapies correctly and help them stay adherent because it is so important. But man, that just adds a whole nother layer to it, doesn't it?
Absolutely. As much as in oncology, we love the fact that many treatments are becoming oral, I think it's a huge cultural shift to suddenly think about how for decades and decades, we as the healthcare teams administered their treatments for them. And now for such an important life-altering disease, we're now suddenly saying to patients, oh, hey, you're going to be really in control of your therapy at home. And I can only really imagine what the burden must be to some people. And just as a healthcare provider and pharmacist, I try to truly do everything that I can to help support them on that journey and make it more palatable for them and reduce that burden for them.
It's a different way to care for patients and having them in our contained little environment, whether it's for infusion or radiation, seeing them all the time, having that touch point with them, both for us as the clinicians and the patient, that provides a level of comfort. And so when we're sending them off on their own with themselves, their caregivers, with a bundle of instructions, obviously we're still trying to be available to coach them and give them education and advice when needed. But it removes that sort of feeling of control that we as clinicians, I think, like, because it does let us intervene and, again, provide that support and the education in a more direct way. And so this is not new. This is not unique to this drug class, but I think it just emphasizes the importance of considering how we support those patients when their only therapy is oral. And so they themselves are the administrators at home. Just a great, interesting conversation and thought about that. And again, it applies to much beyond this, but it just brings it back to the surface of how important approaching that education and that support for patients who are giving their own therapies to themselves at home needs to be different. So along those lines, continuing in that thread, what are some of those primary patient education points that we should be communicating to patients and their caregivers when they're taking their CYP17 inhibitors?
I like to emphasize with my patients that CYP17 inhibitors are not what we call chemotherapy and are really better described as a type of hormonal therapy that decreases the amount of testosterone your body produces. Patients should attend all of their laboratory visits. And I know that doesn't sound controversial, but certainly we do have our patients who need a little bit more reminders and whatnot, and perhaps support even to ensure that they are able to do all their laboratory visits, because we really need to safely monitor their liver function and electrolytes. And electrolytes, I think some people are a little bit surprised to hear, but I mean that in the sense that it's just as important that we look at those electrolytes because that may be an early indicator of mineralocorticoid excess, right? So we talked earlier about hypokalemia can occur. And I think that's just another reason why we need to be looking comprehensively at all of their labs. Patients should also be counseled to alert their team if they do notice the side effects of the mineralocorticoid excess. The one primarily that they might be able to notice is edema, or if they're monitoring their blood pressure at home, perhaps they could self-monitor and document changes in their blood pressure, and such as in a blood pressure journal, if they were interested in that, or if they've been doing that before because they're on antihypertensive medicines. While I, of course, recommend that patients take the standard formulation of abiraterone on an empty stomach, conversely, I do recommend patients take their steroids with food to reduce the chances of GI upset from their steroids. And so I emphasize to these patients that abiraterone and the steroid do not need to be taken together at the same time, even though they are both a component of their treatment, and that they probably should, in fact, take them a little bit separately.
Yeah, it struck me as, when we talked about how the steroid dosing is consistent and part of therapy. I think patients usually come into these therapies with a familiarity with steroids for some other reason. Obviously, they're given for a lot of different things. And so many patients or their caregivers have had to take steroids at some point for something. And then they're going to bring all of their, fears and side effects that they are wary of or anticipating with that. And so it seems interesting that they might actually be less likely to take their steroid because they kind of know what potentially could result from that, and maybe not as concerned with taking their abiraterone, their CYP17 inhibitor. And so again, that coaching of just the importance of taking them together, acknowledging that, yes, there can be taking them together in terms of as part of their ongoing therapy. But as you mentioned, some strategies to space them out differently just to help avoid some of those side effects that we know are specifically associated with that accompanying steroid. Those might be some nuanced conversations to have with your patients just to clarify the importance, but the ways that we can help support them to avoid some of those unique independent side effects.
Absolutely.
So how do you see pharmacists and oncology nurses, how can we best collaborate to help manage these events, these toxicities for patients, provide their education, and really just serve as that trusted source of support and information as they take these CYP17 inhibitors as part of their therapy for prostate cancer?
In my daily role, at least, I'm often asked to review and evaluate potential new drug interactions when changes to patients' current medications occur, either internally or externally from perhaps their primary care physician. And I'm often asked to comment on ways to treat our patients with pharmacotherapy if they are having side effects or if they are having comorbidities of their disease. But because I am the lone pharmacist in my clinic, but we have multiple nurses that work daily, I do rely on them to be able to communicate with hundreds of patients that we care for. My nurse colleagues are extremely skilled with triage and assessment of any type of ailment that a patient could report. And so often the providers, the nurses, and then myself are all consulted, and we reach out to each other to manage these issues in a very teamwork-based approach. I think one of the best ways to establish trust with patients is really to be genuine and honest when you don't know an answer, but that you know how to find it out or you know who to speak to find out that answer. Nurses in my clinic do patient education for many of our systemic treatments for prostate cancer, again, because of it's really just me out there, but I need kind of the support and help to, again, be able to educate our numerous patients. But sometimes they do get asked to join them for visits when you get the occasional patient who has some really deep questions about their therapy. And I'm always happy to support our nurses and then provide my own expertise to these patients.
Absolutely. And I know various locations and clinic setups and sort of team care models are different across institutions, I know, but I can honestly say that when I've had the pleasure of working in an environment where there is a clinical pharmacist based in that outpatient clinic there as a consistent resource, man, I would never go back. As you've pointed out, we have distinct skill sets and there is overlap, but it is so wonderful to have that partnership at the fingertips to be able to just turn to your partner in clinic or maybe they're in just a slightly separate room, but just to be able to have that connection and that consistency. As you said, some patients have basic questions and that partnership between pharmacy and nurse, that's kind of that daily routine, but some have very in-depth questions or they have a very extensive list of other prescriptions, lots of comorbidities to manage, and it becomes a very complex discussion. And so I think you've provided those great examples of how working in tandem and having that relationship between nurses and pharmacists is only to the benefit of the patient. And so it's great to have that ability to work hand in hand to provide whatever level of support that patient needs. So what do you think the future looks like for these agents in their role in the landscape of cancer care?
I think in the advanced setting, we've reached the limit on CYP17 inhibitors as monotherapy, but I'm not counting ADT in addition to that because ADT is effectively always given with CYP17 inhibitors and some other novel hormonal therapies, which are a different mechanism than CYP17. So now we're really in the phase of studying combination treatments, and we've had some really good results so far. So one of the combinations that made a splash a few years ago is what we call triplet therapy. So abiraterone plus docetaxel plus ADT, docetaxel being a traditional cytotoxic chemotherapy that's been used in prostate cancer for several decades now, but now we're combining it with CYP17 inhibitors and other novel hormonal therapies, which has been exciting. So this has been implemented into the standard of care for metastatic hormone-sensitive prostate cancer. We've also seen the FDA approval of several novel hormonal therapies, including abiraterone, combined with the class of what we call PARP inhibitors. So I think that's good evidence right now that we're seeing these different combinations of chemotherapy and CYP17 inhibitors, abiraterone and CYP17 inhibitors. And I know there's more clinical trials on those combinations ongoing now as well. I also know that there's several novel mechanisms and first-in-class investigational medicines that are being studied currently, including at our center, in combination with CYP17 inhibitors. And we're also seeing more data now that shows that we can improve survival by using CYP17 inhibitors when prostate cancer is more localized and not just in the advanced setting. So kind of everything that we've talked about up until this point has really been about the benefits in prostate cancer have been seen in kind of the more advanced setting. So metastatic hormone sensitive or metastatic hormone resistant prostate cancer, which, by the way, is kind of synonymous with castrate that I've mentioned several times before, but some people don't like to use that older terminology of castrate.
Well, thank you for that. It sounds like this may just be the beginning. Sounds like there's lots of work underway to understand how they can be used in combination with other agents, or as you said, maybe at different time points throughout the disease trajectory. So something to keep our eyes on for sure. Well, thank you, Andrew, for all of your great knowledge, expertise today that you shared with us. I always learn something on these episodes. As we reach the end of today's episode, we do like to always finish things off with a quick fire series of questions to help summarize what we've talked about. So to start that off, how can healthcare professionals evaluate their own implicit or hidden bias about patients receiving CYP17 inhibitors?
I do say this from personal experience. I know that because CYP17 inhibitors are technically a hormonal therapy, there are healthcare providers who consider abiraterone to be extremely safe and honestly not deserving of the same level of clinical scrutiny or monitoring as we might do with chemotherapy or other oral targeted therapies. I disagree with this, and I have seen severe hepatotoxicity and hypokalemia emerge during treatment from what I consider to be a very potent anti-cancer therapy. And honestly, I believe that centers should have well-defined processes or prescribing and monitoring of all anti-cancer therapies, regardless of their perceived safety.
What are some of the common misconceptions about CYP17 inhibitors?
Because of its potency and its risks, I don't think abiraterone is generally as safe as, again, some of my colleagues might argue. And I advocate that it should be handled as we would other hazardous medicines. So again, when I actually say hazardous in that case, I kind of truly mean precautions around hazardous medications, right? Which I know is no stranger to of a concept to nurses who work in oncology. So I described earlier that there are risks to people who are pregnant, but I'm also a firm believer in promoting safe handling habits, including storing securely, washing hands after taking this medicine as some examples of how patients can do that, or how providers, if they need to touch the medicine, can do that as well. As I say to patients, we should never expose a person to a cancer treatment if they don't have a reason to be.
I love that. And I think you're absolutely right that the notion of hazardous drugs, I think some people's minds automatically go to kind of the worst of the worst, but there's a certain level of hazard that all drugs bring, especially in the space of treating cancer. And as you said, there are habits, there are practices that should be universal when handling any sort of potentially hazardous drug, regardless of what that hazard is. And so I love that. And I think you're absolutely right. That's something we should reinforce and be consistent with for all of our patients. What's something about this topic that's not often discussed, but you wish people knew more about?
I think this is probably discussed in specialized clinics like I work in, but if you aren't aware, the manufacturer of the original brand of the standard formulation of abiraterone discontinued their patient assistance program just a couple of years ago. And we were left with a lot of patients who were looking for resources to be able to afford this medicine, despite having been on it for several months or years already. Some of the ways that we kind of found to address that is, so the Mark Cuban Cost Plus Drug Company does offer abiraterone with its unique pricing scheme that differs from the traditional pharmacy model. I think a lot of patients are familiar with his pharmacy. He really made it public that he was going to kind of challenge kind of the traditional pharmacy model, which I'm not going to comment on what exactly that looks like for a patient, but I did want to just explain that it is one of the cancer medicines that is actually available through that pharmacy, which is, I think, good for our patients. Other brick and mortar community pharmacies may be willing to fill this medicine, but because it is considered high cost, some pharmacies might not want to assume the financial risk of stocking this medicine. And therefore, specialty pharmacies, oftentimes mail order pharmacies, may still be necessary for a patient to fill with, even if a patient doesn't want to fill with that and they want to fill with their local pharmacy. Ultimately, I think institutional resources that support patient affordability and access to this medicine should always be offered to any patient.
What training or education do you think oncology nurses need to stay current on this topic?
So genetic testing and targetable mutations are really on the rise in the management of prostate cancer, and also not necessarily screening of prostate cancer, but understanding how we can help families who may be at risk for kind of a genetic risk of prostate cancer, so how we can help those families as a whole. So I would encourage nurses who practice in really any oncology spaces, but especially in genitourinary oncology spaces, to understand the role of genetic testing in prostate cancer and some of the mutations of interest.
Absolutely. I think that is becoming the norm for all of oncology, right? Understanding biomarkers, understanding precision oncology. Proud to say that ONS has several resources that can help support nurses exploring that, specifically our biomarker database, which can be accessed for free. And so I hope nurses who aren't familiar with the biomarker database, check that out. We'll be sure to include a link to that in our episode notes as well. And finally, what are some additional resources for patients or maybe other providers who want to learn more?
ONS collaborated actually with several other organizations. So NCODA, HOPA and ACCC to develop excellent patient education resources for many different cancer treatments that we're not even, of course, talking about today, both in prostate cancer and beyond, including our CYP17 inhibitors.
Well, thank you again, Andrew, for spending time with us today and sharing all of your wisdom and great information with us and our listeners. Do you have any final comments to share?
I think we're in a scientific golden age for prostate cancer and probably cancer as a whole, but we're talking about prostate cancer today. So I'm excited to be sitting on the front lines, seeing the new ways that we can help our patients. But I do still think CYP17 inhibitors will continue to be one of our main weapons against prostate cancer for a very long time.
Very well said. Thank you so much.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.